Hello, my name is Alexandra and I will begin our video on Allen's cognitive model in occupational therapy. Cognitive ability is a key factor in how someone engages in daily occupations, and for this reason, it is important to understand in relation to OT practice. Allen's cognitive model was developed by Claudia Allen and includes six cognitive levels that connect cognitive processes to functional performance. The six cognitive levels guides therapists in determining the amount of assistance a client may need. At the lowest level, client may only respond to simple cues and need food assistance. At the middle level, they can repeat routines with supervision and reminders. At higher level, clients can plan, problem solve, and manage tasks with more independence. In 1985, Allen published the Allen Cognitive Level Screen, or ACLS, based on the letter lacing task. In this task, clients complete stitching patterns so therapists can observe how they follow instructions, how they recognize errors, and problem solve. Claudia Allen developed this model while working with adults with schizophrenia and depression. The main idea of Allen's model is to focus on what clients can do rather than the limitations. This allows therapists to adapt tasks and promote independence and safety. Research shows ACLS scores help determine the right amount of supervision and support. The principle is that cognition drives function. How people process information impacts how they function. Occupational therapists do not remediate disability but improve remaining strengths so clients can live as independently and safety as possible. The model balances independence, safety, and quality of life.
Hello, everyone. My name is Adelaja Alaba, and I'll be highlighting and defining the three most important factors that help us reach our desired outcome of the Allen Cognitive Model. Now, the desired outcome of the Allen Cognitive Model, as we just went over, improving safety, the independence, and meaningful participation in clients' daily activities. So, the first concept I'd like to highlight is the cognitive level of functioning. These are the six hierarchical levels ranging from automatic to planned actions that describe predictable patterns of cognitive ability. Now, this factor pushes us towards our desired outcome because once identified, the levels help determine what a person can do independently, what they can do with support, and what they cannot do reliably. Now, the second concept I would like to highlight that pushes us towards our desired outcome is performance as assessment. Now, this is the real life task performance to reveal functional cognition. This factor pushes us towards our desired outcome by showing how people process information, follow cues, and problem solve. With this information, we're able to form the basis of our intervention planning. So, the third concept that pushes us towards our desired goal is environmental cues and supports. Now, this is where tasks and environments are matched to the person's cognitive level, allowing for safe and successful participation. This factor pushes us towards our desired outcome because we're now realizing that supports, such as structured routines or maybe even visual cues, can create what the ACL likes to call the just right challenge. Now, structured environment, it fosters independence and safety. Those were the three main factors that help push us towards our desired outcome within the Allen Cognitive Levels model. Thank you for listening.
Hi everyone, my name is Michelle McFarlane and I'll be presenting on the collaborators. The cognitive disabilities model was first introduced by Claudia K. Allen, and she drew research not only from occupational therapy but areas such as psychiatry, neuropsychology, cognition, and rehabilitation sciences. She started her work in the 1960s at the Eastern Pennsylvania Psychiatric Institute, where she first observed performance difficulties in mental health disorder patients. A key collaborator to her work was also occupational therapist Catherine Earhart, who worked with her from 1974 to 1995. Together, they conducted research to develop the model and four versions of the Allen Cognitive Level Screen. She also collaborated in research with philosophy professor Reginald E. Allen in 1987 and occupational therapist Tina Blue in 1992 and 1998. Allen continued her work with Earhart, forming their foundation Allen Cognitive Group, and though Allen passed away in 2019, Earhart continues to serve as a director advocating for the continued education and research in the model. Now let's move over to slide 2. Functional disabilities continuum. The slide has 2 questions. 1. How does this model apply to individual client functioning? 1. The model rates cognition based on its 6 hierarchical levels. 2. It rates areas of planning, self-monitoring, information processing skills, and adaptability. And 3. It seeks to optimize what the client can do at their current level through their environmental and activity modifications to ensure safety and success. Second question, what disabilities might a client have which prevent him or her from achieving the desired outcomes? Disabilities such as acquired brain injuries, dementia, schizophrenia, and autism. Now I'll pass over to Jennifer, who will continue our presentation.
Thanks, Michelle. The Allen cognitive theory emphasizes that change occurs when OTs establish a just right fit between an individual's cognitive capacity, activity demand, and the level of environmental support. When this alignment is achieved, clients can participate successfully in daily occupations and experience positive, sustainable change. To gain deeper insight into a client's functioning, OTs rely on both clinical observation and standardized assessment. Research by Wesson and colleagues demonstrated tailoring community fall prevention programs to an individual's cognitive level improved participation and outcomes. Adaptations included simplified instructions, visual cues, and home safety modifications as outlined in the slide. Therapists also assess client goals, values, interests, and contextual factors such as environmental supports and barriers to ensure interventions are both client-centered and realistic. Observations of physical capacities, cognitive functions, and environmental influences further inform treatment planning. Assessments are all available on the slides that I will reference, but the key assessment is the Allen Cognitive Level Screen, which evaluates global functional cognition through a battery of stitching tasks of increasing complexity. Additional tools include the ADM and the RTI expanded and provide further information on learning potential, functional performance, and daily task engagement.
Thank you. My name is Yvette Pena, and I'm going to be speaking in reference to methods and techniques that clinicians use during interventions while using the Allen's cognitive model. So this theory provides a set of intervention techniques based on the client's cognitive level. The interventions are designed to compensate for the client's cognitive limitation and to maximize functional participation in meaningful occupations. Interventions using this model include activity analysis and task simplification, environmental modifications, meaningful occupations, and compensatory strategies. The clinician can grade the activity demand based on the client's cognitive level to reduce any type of frustration. This in all is to maximize safety, independence, and quality of life. So here is an example of the interventions that are applied based on the Allen cognitive levels. This includes intervention focuses, levels of assistance, and activities. These 3 studies that provide evidence of the Allen cognitive model. The first one is the functional performance and the Allen cognitive level screening for adults with mental illnesses, which examined 15 studies in the relationship between the Allen cognitive level screening and the functional performance in adults with mental illness. The second one, where an OT practitioner used the ACLS-5 and routine task inventory to guide intervention planning with a client with schizophrenia. So interventions used in this study included supported employment, structured routines for ADLs and IDLs, and environmental cues. And lastly was on the clinical validation study of the Allen cognitive level screen in brain injury, which examined the validity of the ACLS in relationship to functional outcomes, specifically to the individuals who suffered from a brain injury. To synthesize these studies, they all reinforce the ACLS as an occupational-based insight into functional cognition. It is valid for immediate functional performance based on the cognitive levels, which can give insight to clinicians on how they can perform in the moment. It concludes that the ACLS is a great tool for assessing clients and adapting their interventions based on their cognitive level. Thank you again for watching in.